I'll start by saying, why is it important? Oh, these are my conflicts of interest, very few. And why is systemic hypotension important to even care about? Well, we have so many population-based studies at this point in so many different populations that show an increased prevalence of glaucoma with low blood pressure and or low perfusion pressure. Here we see in the Baltimore Eye Survey, subjects with low diastolic perfusion pressure had a 6 times increase in open-angle glaucoma prevalence. And again, in Predictive Air with the Hispanic population in Arizona, again, low diastolic perfusion pressure with increased prevalence of glaucoma. Similar findings in the Singapore Eye Study, similar findings in the EGNA-Newmark study in Italy, and again in the Los Angeles Latino Eye Study. In this study, there was a J-shaped finding with increased prevalence of glaucoma with low diastolic pressures, perfusion pressures, as well as high. And that might also relate the high with prolonged hypertension causing autonomic dysfunction. There's also studies showing increased incidence of glaucoma with low perfusion pressure. In the Barbados study with looking at African origin participants, there was a higher incidence of open-angle glaucoma with lower systolic, diastolic, and mean perfusion pressures. But not all studies show this definite relationship. In the Rotterdam 20-year follow-up, there was not a relationship between blood pressure and incident glaucoma. Well, what about progression of glaucoma? The early manifest glaucoma trial found that low baseline systolic perfusion pressure was a significant predictor of progression. And there's accumulated now a large body of evidence that nocturnal hypotension may be a strong risk factor for glaucoma progression. Nocturnal dipping of blood pressure is normal, it's physiologic. Most people have a 10% dip in blood pressure during sleep, and it's protective against cardiovascular mortality. About 10% of the population don't dip, and they have increased risk factors for cardiovascular disease. Despite physiologic blood pressure dipping at night, as well as IOP elevation, ocular perfusion pressure generally increases as we lay down and our heart aligns with our eyes. So typically, the nocturnal dips of pressure of about 10 millimeters should not result in ischemic injury in normal eyes. But what if the dips are not typical? There is a large body of evidence that shows greater dips in nocturnal blood pressure are associated with an increased risk of glaucoma progression. I wish I had the time to go through all of these wonderful studies, but you can read them on your own. And we also have learned in 2 recent studies that baseline nocturnal dips are predictive of future glaucoma progression. This was a study of 65 normal tension glaucoma eyes, and Kwan's study was 119 normal tension glaucoma eyes, where they looked at baseline ambulatory 24-hour blood pressure readings, and they found that it was predictive of subsequent progression. So what do we do? If we lived in an ideal world, we would be able to really calculate ocular perfusion pressure over the 24-hour cycle. We would be able to measure ophthalmic artery pressure. We would all live in San Diego, where we had a nice sleep lab that could measure pressure over 24 hours. And we would have continuous 24-hour intraocular pressure monitoring. This is showing the triggerfish device, which can tell you relative pressure movements in the eye over 24 hours, but we certainly at this point can't use this on regular clinical patients. Ambulatory blood pressure readings are critical in evaluating these patients. You need to know what they're doing by day, what they're doing by night in terms of their blood pressure. Ideally, we'd all work with a cardiologist. We'd send our patients over and they'd take care of it, but it's hard. It's hard to find a doctor that will work with you. So I just bought my own unit. I bought an inexpensive unit that works very nicely, and I can just do it on my patients myself. And this is just one printout I have on one of my patients who, as we see, has low blood pressure all the time, but at night, her diastolic pressures are typically in the 40 to 45 range. And this is important information to have, so I can't stress enough the importance of ambulatory blood pressure measurements. So what do you do when you find out your patient has low blood pressure? Well, is it from medications? Are they being treated for hypertension? In which case, it's very important to work with your primary care and cardiologist to coordinate and make sure that you each understand what your concerns are, that they know that you're worried about blindness, you know that they're worried about mortality, and discuss realistic blood pressure goals. Not everyone needs a very low blood pressure, which is what the cardiovascular doctors often want. So prevent overtreatment of systemic hypertension, avoid nocturnal peak effect of the antihypertensives, and consider alternatives to calcium channel blockers, which were shown to be a negative risk factor in the Rotterdam study. Well, what if your patient is not on blood pressure medicine and they have untreated hypotension? Still discuss blood pressure variability, orthostasis, autonomic dysfunction with the medical doctor, encourage patients to stay hydrated, discourage salt restriction, which they may be doing if a spouse has high blood pressure. It's unclear what we do in terms of salt supplementation, mineralocorticoids. We know that we can raise blood pressure. We don't know what it does necessarily to other vascular beds. And then remember that lowering intraocular pressure is the best studied mechanism for increasing ocular perfusion pressure. Evaluate intraocular pressure variability. You can check measures at different times of the day. You can use supine blood pressure as a surrogate for nocturnal IOP spikes. And consider different medications when you are trying to treat these patients. You want to not lower nocturnal, you want to lower nocturnal intraocular pressure, so you want to avoid beta blockers, which don't work at night and can also lower systemic blood pressure. So consider prostaglandins, carbonic anhydrase inhibitors, maybe Rho kinase inhibitors. Consider non-vasoactive drops. Possible direct effects of the different vasoactive medications on blood vessels can have effects that we may not be aware of. The Logit study supported brimonidine over timolol. There are some concerns with lowering of blood pressure with brimonidine, but not as much as beta blockers. Consider carbonic anhydrase inhibitors, which may increase blood flow to the eye in excess of the intraocular pressure. There may be theoretical benefits from nitric oxide donating prostaglandins. There may be theoretical benefits from Rho kinase inhibitors that can decrease pressure below episcleral venous pressure and encourage punctal occlusion to minimize systemic absorption. Surgical treatment can lower pressure without the confounding effects of vasoactive medicines. Surgical treatments lower pressure and they decrease variability of pressure with less nocturnal elevation of pressure. And so in summary, most studies demonstrate that low ocular perfusion pressure is associated with an increased prevalence, incidence, and progression of glaucoma. Intraocular pressure increases at night when we go into the supine position. Large nocturnal blood pressure dips can significantly decrease ocular perfusion and are associated with glaucoma progression. Ambulatory blood pressure monitoring is key to understanding a patient's circadian blood pressure and risk of overdipping at night. Lowering intraocular pressure is key to improving ocular perfusion, and there are therapeutic choices that we can make to help minimize the detrimental effect of systemic hypotension. And when all else fails, a little resveratrol may be helpful as well. Thank you.